So good afternoon, everyone. Just in terms of logistics, I think when you registered, we asked if you wouldn't mind if recorded the meeting, but I should just apparently officially double check with you all that you know you are being recorded, and Valeria's already pressed the record button. So thank you for that. If you don't want to be recorded, we'll see you next time. But hopefully you'll all stay. So thank you. And the second thing is, please could you all mute when you're not talking, or, you know, my dog will bark, or, you know, someone will get a delivery or something will happen. But if you could all mute when you're not talking, and then please remember to unmute when you do ask questions, that would be fantastic. Okay, so thank you for coming along this morning. This is the ARC, NIH, here comes an acronym, NIHR, ARC, Northwest Coast Methodological Subgroup on Health Economics, which shouldn't be a surprise to you because you all enrolled to come. So thank you all for coming along. I'm not going to go into it in too much detail because we're going to send around a little survey afterwards to you all about this. But along the Northwest Coast, there is felt to be a need for more health economics support. Now, the idea of this group is it's going to be very user driven. So we're not, although we have set up some talks in our first meeting on inequalities, which is kind of the theme of the Northwest Coast ARC grant. What we're really going to do, hopefully, is be driven by what you want in terms of users of health economics and people who are interested in health economics. So one thing we're going to do is today we're going to have some talks from our esteemed panel of speakers and some questions, and then Valerio is going to take over after the talks and do a quick poll of 4 or 5 questions, Valerio, something like that, to find out just some initial thoughts about what you want. And then we're going to send around a quick survey afterwards to you all for a little bit more detail on what you might be interested in terms of future meetings, different doorbell sounds when people arrive, things like that. Okay, so we'll get some more information out of everyone. It's generally speaking going to be today people who are interested in health economics, interested in what's going on, but then as the group evolves, it'll become people who are more and more interested. You don't have to be a health economist to come along. Okay, there will be some of us here who are. That's the idea. And inequalities is the general theme of the group in terms of health economics to fit in within the Northwest Coast. So this will evolve more. We'll find out more about who each other are, and the next meeting will be in the autumn, in September, around themed a little bit around the area of choice experiments and health economics and how they can be of use to people. So what we might do is get going today, because it's already 5 past, looking at my timetable. So we're going to have 3 talks today about health economics inequalities, and we're going to start off, if I can get the right slides up here, a talk entitled, hopefully, Regional Health and Economic Inequalities Before the COVID-19 Pandemic. There was a time before there was a COVID-19 pandemic, people, and it's Dr. Sophie Wickham, who is from the University of Liverpool. So we're going to have 3 talks of hopefully 20 minutes or less each, then about 5 minutes for questions. If you've got any burning questions that you think you'll forget, stick them in the chat and we'll ask them afterwards. But otherwise, you can maybe just shout up afterwards, after Sophie's spoken. And then we'll have our second talk by Luke and our third talk by Brendan. So thanks very much to our speakers, especially for pitching up today and offering to talk. And Sophie, if I could hand over to you to share your screen, that would be wonderful. Mm-hmm. Thank you very much.
Can everybody see that?
Perfect.
Excellent. Just there we go. I'm just going to minimize all of you. There we go. Okay, so hello and thank you for inviting me to talk with you all today. So my name's Sophie. I'm a Wellcome Trust Research Fellow and a member of the Northern Health Science Alliance. And today I wanted to talk about the health of the the health of the North and using some Liverpool specific analyses as examples. Now, a lot of the things that I'll be presenting today have come out of this report here, COVID-19 and the Northern Powerhouse, Tackling Inequalities for UK and Health Productivity. So I'd really recommend, if you haven't seen it, go and have a look. And as a headline, if you take nothing else home from the things that I talk about and potentially what the other speakers have talked about, I wanted to get this across, that the north of England's health and economy has been hit harder than the rest of the country, not just during the COVID-19 pandemic, but also before the pandemic. And those pre-existing inequalities that we saw before COVID-19 between the north and the rest of the country have exacerbated the problem, which has cost significant lives. So what do we mean when we talk about the North? Well, it encompasses 77 local authorities that cover the North East, the North West, and Yorkshire and Humber. And on the right here, we see the distribution of deprivation. The Northern Powerhouse has the highest percentage of local authority districts within the most deprived quintile. So this is the 20% of the most deprived areas. Here, with 41% of all local authority districts within the Northern Powerhouse in the most deprived areas nationally. And this compares with just 5% in the South. And when you look at the least deprived, only 66% are in the least deprived local authority districts are within the North, with 31% in the South. And I think it's important here to highlight what's going on in the Northeast, where you see there's no local authorities in those bottom two least deprived areas. Now, using Liverpool as an example of what we're seeing health-wise, so today in Liverpool, we've seen 1,300 excess deaths in Liverpool compared to the rest of England. We've seen more than 13,000 people living with a disability compared to the rest of England. We've seen 20,000 more people living with mental health difficulties compared to the rest of England. This image here on the right shows the large mental health inequalities that we are seeing across England, and it focuses down on Liverpool, with those blood red colours indicating worse mental health and the bright blue better mental health. We've seen over 31,000 children living in poverty in Liverpool. That's 1,000 more than the previous year, and 6,000 more than 5 years ago. And perhaps what is more concerning and what we're seeing now is that these figures, they're not improving, they're not flattening, they're getting significantly worse. And the devastating impact that these can have on families and communities is absolutely immense. But I have told a fib. This is not Liverpool today. These figures are from 2018, 2019. And of course, no one was reading these numbers out at daily press briefings that we saw in the beginning of the COVID pandemic. And in fact, there was a deafening silence. And as we know, these are not numbers. These are people's lives, and the same devastating effect that we're now seeing with the impact of COVID-19 has been experienced for many years, with the same effects on families as people's lives have been cut short. Now, all the data that I'll be presenting to you for the rest of the talk is data that is before the COVID-19 pandemic started to impact our lives in 2020. So child poverty has particularly suffered. In 2019, there were over 4.3 million children living in poverty in the UK after housing costs. And child poverty has risen by around 500,000 since 2010, which has reversed a longer term trend of falling poverty. Now, these figures here show the percentage of children that are living in relative poverty by local authority in England. And poverty data here is taken from the DWP's Children in Low Income Families database. And these provide annual statistics based on the financial year on the number and proportion of children that are living in relative and absolute low income before housing costs by local area across the UK. And these maps show what's happening in England. They show the proportion of children living in absolute and relative low income families in England for the financial year. So that runs from April 2019 to the end of March 2020. There's a large concentration of children living in poverty in the Northern Powerhouse regions. And you can see the North Powerhouse regions are marked by this kind of dark line here. So compared to England's average, 58% of local authorities within the northern regions experienced above average levels of children living in low-income families, and this compares to only 19% of local authorities within the rest of England. This figure presents the relative child poverty rates after housing costs over time and compares the 3 northern regions with the UK as a whole. So it might be a bit small for you to see here, but this one's the northeast, the blue line, the orange one's the northwest, and the grey one's Yorkshire and Humber, and then this one's the average across all children, the yellow one there. So we see high points in the 1990s where we have high rates of child poverty, particularly in the north regions. And then it fell faster than the rest of the UK, particularly in the northeast. Until the time of the global economic crisis, the northeast and Yorkshire Humber had rates that were close to or below the UK average rate. But from around 2014, 2015, it began to rise again, and children living in poverty rose much faster in all the northern regions compared to children like the average UK children as a whole. And once again, we're seeing this gap rise. It's an injustice that a child born in Kensington and Liverpool, for example, can expect to live 10 fewer years than a child born in somewhere like Kensington and London. And this rises to 20 years if we think about life lived in good health. Now, if we think beyond Liverpool, what COVID has done is it has shone a light on what many of us already know, is that these health inequalities, these massive differences in health between people and places, have been a blight on this country for many years. England's regional health inequalities are now some of the largest in Europe, and I think in 2016, according to EU data, 6 of the UK's regions were in the bottom 10 according to GDP per person when comparing to its nearby countries. So the UK is not performing well, and there are deep-rooted and persistent regional inequalities in health across England, with people in the north consistently found to be less healthy than those in the south, across all social groups and among both men and women. There's around a 2-year life expectancy gap between the northern powerhouse and the rest of England, and the health profile of the north is generally worse. We have greater deaths from cardiovascular disease, more cancers, more diabetes, and a greater proportion of people categorised as obese or overweight. The premature death rates are 20% higher for those living in the north across all age groups. And over the last 50 years, this is equivalent to over 1.5 million northerners dying earlier than if they had experienced the same lifetime chances, health chances, as those in the rest of England. Now, if we look at women's life expectancy, and there's a reason I've chosen women's and not men's, this image here on the right reflects an English train journey that you might take, and it reflects the life expectancy for women along the East and West Coast main lines. And you can see is that what you can see is the further north you go, life expectancy falls. So those circles represent values that are above average in green, around the same in orange, or below in red, the English average of 83.1 years for women. Now, the picture that you see for men is similar, but the reason I've chosen women is because what we're finding is that it is even more concerning that it is falling fast and faster for women in our most deprived communities within the north. So for the first time in decades, it started to go backwards. So this image here on the right shows the life expectancy for Liverpool and the rest of England. Liverpool is represented by red. And we can see that it's consistently lower than England's average from around 2003 to 2013, but it is rising parallel to England's. However, in 2013, whilst England's average is stalling, what's happening in Liverpool is it is taking a downturn, and that downturn hasn't stopped. Again, if we look beyond Liverpool, in the most deprived areas, we are seeing a decline in life expectancy, whereas in more affluent areas, it remains constant, widening these health inequalities. In the last 5 years of data, 108 local authorities out of 306 local authorities in England saw a fall in life expectancy at birth for men, and 124 for women, with 51 areas saw this decrease for both men and women. one of the biggest reasons we see this north-south divide is that these high rates of deprivation within the north. So almost half of local authorities in the north experience such a decline. And in recent years, the north-south health divide has widened, with the gap in life expectancy at birth increasing from around 1.37 to 1.74 for men and 1.6 to 1.76 for women. And make no mistake, these differences in health, they're avoidable. So another sensitive indicator of the health of our country and policy changes is infant mortality. Infant mortality is the death of a child before their first birthday. Infant mortality has been falling steadily across all of England this century. But in 2013, this trend started to change. Infant mortality began to rise in income-deprived parts of the country, but not in more affluent areas. And researchers found that an estimated 172 deaths between 2014 and 2017 were attributable to increases in relative child poverty. This was almost a third of the overall rise in infant mortality over that same period, indicating that child poverty is a significant contributing factor to our rising infant mortality rates in deprived areas. And based on those trends, they estimated an additional 570 excess deaths in the period of 2014 to 2017 than would have been expected if the historical trends had continued. And a recent report by Odd et al. In 2021, so just came out, I think, a couple of weeks ago, looked at the National Child Mortality Database using data on deprivation, which was measured by the Index of Multiple Deprivation in 2019, and child mortality. And they measured children from the ages of 0 to 17 that reported between April 2019 and March 2020. And they found that significantly more deaths occurred in more deprived areas. I've just lost my place. More deprived areas in the UK than in the least deprived, and with the most deaths occurring under the age of 1. So really affecting those in the early years. The report highlighted that over a fifth of all children deaths may have been avoided if children living in the most deprived areas had the same mortality risk or the same life chances as those living in the least deprived. And they translated this to over 700 fewer children dying per year. Now, these differences in health, they're caused by differences in access to resources that are needed for good health. So again, in Liverpool, we've done some specific analysis looking at what explains those differences. So in this image here on the right shows the percentage of the mortality gap between Liverpool and the rest of England and what these are attributable to. So going back to Liverpool's 1,300 more deaths that we saw in 2018-2019, analysis by colleagues within our team have shown that 35% is explained by living on a low income. 26% are due to environmental factors, and these include things like crime, access to green spaces, and air pollution. 20% are due to employment status, so whether you're in employment or not, and 18% is due to educational factors like attainment level. We need to be working on improving access to resources that are needed for good health, ensuring resources are going to areas of need, which historically has not been the case. And if that argument doesn't sway you, we should be looking at the impact on the economy. So if we look at productivity, and by productivity I mean economic productivity, which is generally lower in the north, and a key reason is that the health is also worse in the north. So we have long-term health conditions that lead to periods of economic inactivity and spells of ill health, which increase the risk of job loss and lead to lower wages when people do return to work. So improving the health of the north would lead to substantial economic gains. And again, analysis that we did for the Liverpool City region demonstrates that a third of this productivity gap between the Liverpool City region and the rest of England is in fact due to ill health. And that if we reduce this observed health gap, we would generate an additional 3.2 billion into the economy. And this is just the Liverpool City region. So reducing that health gap throughout the whole of the north by reducing this north-south health divide would generate an additional 13.2 billion into the economy. This cost of austerity is clear. Local government spending, which has fallen by around 24%, which is almost £30 billion over the last 10 years. And by the last 10 years, I'm talking about 2009 to 2010 to around 2018, 2019. So again, pre-pandemic times. These have not fallen evenly across the country and have not gone to areas of need. So this image on the right here shows the change in spending power per person for all local authority services in England over the past 10 years. And spending power is a measure of overall revenue funding available to local authorities and includes council tax and local retained business rates. And this map shows that deprived communities with higher rates of poverty, with weaker economies in the north of England, saw the largest reductions in their local authority budgets. So areas with greatest need have had cuts to much needed resources. So this is where we were in 2019. The message is quite clear. Austerity has cost lives. We've seen more deaths, more disabilities, more mental health difficulties, more children moving into poverty, and a reversal of life expectancy for the first time in decades. And as I said, this was only 2019, before the pandemic struck. Thank you.
Thank you, Sophie. A very powerful talk. I think we're all probably reeling a bit from some of the numbers you've just put up there, but thank you.
Am I still sharing? Yeah, sorry.
You are, but that's fine. You didn't share anything wrongly. Okay, thank you very much. Any questions for Sophie, please? There's not that many of us, so you could always just shout out or raise your hand.
I'm also happy with no questions.
Well, I've got one, so you're not going to get it. Shall I ask my question? Well, my question, so I don't know whether I had a question or a point really. So when we were teaching at the start of the pandemic, the students all wanted a lecture about, you know, the economics of the pandemic, when obviously we didn't really know anything at all about it. So, oh dear, this is being recorded. We knew loads about it on behalf of the students who were watching. Anyway, so we looked up some numbers and figures about what's happening. And of course, test and trace in a year costs 32 billion. And you gave a figure of 29 billion for the fall in funding over 10 years for local councils. So more was spent on test and trace in less than a year than was withdrawn from funding. So, you know, you can put these figures in context, can't you, of what difference would it have made not to do that, you know?
Yeah, you can see the you can see the same with the welfare system as well. So the cuts, so the austerity program, you know, fiscal policy designed to essentially reduce the welfare system, reduce demands on the welfare system, and move people into employment. But of course, there are more people in work poverty now than there ever has been, and 75% of children that are in poverty are in households where somebody is working. If we hadn't seen those cuts and, you know, loss of generosity and all those things within the welfare system, we might be seeing a different picture as to what's happening with the COVID pandemic. But I guess we can't really.
That's true. Resilience and stuff, you mean, beforehand. Sorry, I'll not talk. Brendan, Brendan, you've got your hand up. Thank you. Would you like to speak?
Thanks, Chris. Thanks, Sophie. That was really interesting presentation. One thing I was thinking about, and the details probably in the papers, but you talked about kind of Liverpool City region and the relationship between income and health, and also the relationship between long-term health problems and unemployment. And it seems to me that there's kind of complex dynamics there where you've got time lags and you've also got, I suppose, non-linearities. So if you've got a healthy population with not many jobs, then people will invest because wages might sort of go lower for a time, and it's a good area for investment. So does your analysis include those kind of complex dynamics in there, or is it just assumed there's a kind of linear relationship between unemployment and health?
No, it would have included those extra things, like anything that would have likely have impacted on those trends. So, you know, local authority employment rates, for example, will have gone into those analyses. Trying to think what else would have gone. Population rates, you know, anything that at a local authority level would have changed that relationship.
Thanks.
Patricia, you've put a couple of comments in the chat. Did you want to ask those out loud, or are they just sort of comments for Sophie?
Yeah, it was only about the data that, I mean,
Oh,
thank
okay.
you, Sophie, it's excellent. So just any, articles or anything else you're aware of, reports, it might be reports that are coming out in the future that you're aware, look out for this.
I mean, I'd hold off for Luke's talk for the post 2020 March 2020 stuff, because I wanted to end my sliders over to Luke, but because there was a pause in between, yeah.
Thank you.
Thank you. Lewis, you've got your hand up.
Hi, thank you, Sophie. I have a broad question, maybe too broad even. So at some point you were telling that some differences are avoidable. My question is if the literature or people in general, politicians, have identified how to avoid them. So are there measures in the short term that can be applied, or are they mostly long term, like education, behavioral, income, that will take more time?
I would say the government's stance on avoiding these things, they've really focused on family breakdown as the causal factor in seeing all these negative health consequences. Whereas from a researcher's point of view and a scientific perspective, we would talk about deprivation and poverty being the causal factor. So I would advocate for trying to reduce poverty and trying to reduce child poverty and focusing on the early years, a more generous welfare system that I think we could all benefit from if we found ourselves in facing those adversities. However, at the moment, it seems like the government strategy is to move people into employment, is one, and also refocusing poverty or reframing poverty as family breakdown, which is confabulating cause and effect, I think.
Any final questions or points for Sophie before we then actually do say over to Luke? I suppose, I mean, again, I actually read your paper, but again, because I'll have read it, of course. I said you can't answer this in 1 minute, I'm sure, but, and there's probably lots of reasons, why for women have things changed? Or is it just too much to answer in a minute because it's everything you've been talking about?
I think it is everything that I've been talking about.
Okay.
But if we think back to so there was a report that came out last year, I think, and it talked about winners and losers within the welfare system. And there are always going to be some winners and there are always going to be some losers. And the losers tended to be women, single parent households, which tend to be women and children. And I think those are the things that are contributing to this decline as much. So the fact that women are taking a lot of the burden, which is resulting in that huge shift.
Okay, thank you, Sophie, for the moment. I'll say a proper big thank you at the end, but thank you. That was a very powerful start. So Luke's got some big shoes to fill in talk 2 now, but it's over to Dr. Luke Munford, who's sharing. Thank you, Luke. Who's going to be talking about a year of COVID in the North, regional inequalities and health and economic outcomes. So kind of following on from that, and then Brendan's third talk I'll kind of follow on from this as well. So Luke, I'll hand over to you for your 20 minutes. Thank you very much. Luke's from the University of Manchester, as it says, but I'm guessing possibly isn't in Manchester this afternoon. Over to you, Luke.
Thanks, Bruce. Just to check, you can see my slides, not my presenting.
Yes, no, I can see your slides.
Brilliant. Thank you for the invitation. Thank you for Sophie for setting this up. So as Sophie said, we knew before the pandemic that health outcomes were considerably worse in the north of England. And at the end of last year, we published a report with the NHSA looking at what happened in the first wave. So in the period March 2020 through to July 2020. What I'm going to talk to you today about is the full period. So from March 2020 through to March 2021, April 2021. And I think the really sad, worrying thing is for people living in the north is things haven't got any better, and if anything, they look like they're getting worse. So this really is a shake-up that we need to do something. The government needs to do something to try and remedy some of these widening inequalities. So this is just the all-cause COVID-19 and other cause mortality rates in the 14-month period from March 2020 to April 2021, where the darker red colours are the highest mortality rate. So these mortality rates are age and sex standardised, so it takes into account the unequal distributions of populations. And I think the obvious thing to come out of this is for all three mortality measures, the north of England does worse than the south of England. But it's also important, I mean, we tend to badge the north together as this homogenous thing where it's just all bad up north and all brilliant down south, but there are some areas in the north that do well or have low mortality, and there are some parts of the south that do bad in terms of mortality. And particularly for COVID-19, we know that London was the initial epicentre, and then the southeast had the Kent variant around Christmas. But on average, the north does considerably worse than the rest of England, particularly the southwest. And we can just see this here. So if we look at the mortality rates for all causes in this period, the northeast has the highest, so then the northwest is the second highest, and Yorkshire and the Humber the fourth highest. West Midlands gets lumped in with the rest of England, but it does tend to do quite badly on these mortality measures as well. But again, this is very indicative of what we would have seen before COVID. So if we look at all-cause mortality, those four regions are typically the worst and have the highest mortality rates. And the southeast, the southwest, and the east of London tend to have the lowest mortality rate. So COVID-19, as I said, is a little bit of an anomaly in that London bucks a trend. So London typically has among the lowest mortality rates, but we know it was the epicentre for the first and a bit of the second wave. And as a result of that, that has got the highest COVID-19 mortality rate. But then in second is the northwest, in fourth is the northeast, and fifth is Yorkshire and the Humber. And again, the southwest and southeast tend to have, on average, the lowest mortality rate for COVID-19. And other causes, so things that weren't COVID, so what you typically see in non-COVID times, we get this familiar figure where we've got the northeast, northwest, Yorkshire and the West Midlands having the highest mortality rates. And this is consistent across every month of the pandemic, and then obviously when you group the whole period, you get this result as well. So if you just look at which local authority districts have the highest and lowest mortality rates for all causes. And I think this is quite interesting because these lowest five local authorities are all in London. So despite the fact that London did really badly for COVID-19 mortality, when we look at all cause mortality, there are parts of London that do better than expected. But if you look at these districts in London, they're very affluent. So you've got the City of London, Kensington, Chelsea, Westminster. These are among the least deprived areas in the country. And then we look at the other end of the spectrum, the worst hit areas there are typically in the north. So Manchester has the highest in this period, and then Middlesbrough has the second highest, and Blackpool, which is in northwest coast area, does really badly on mortality, and we know that from before the pandemic as well. So looking at the COVID-19 mortality rates, this is now where we see this London picture really coming through. So apart from Blackburn and Darwin, every one of those highest mortality due to COVID-19 are in London. So London has some of the highest COVID mortality, but also has some of the lowest all-cause mortality. So although London's been badly hit by COVID, it isn't being uniformly badly hit. And again, this is sort of what we'd expect from before the pandemic. And then we've got the southeast and the southwest among the lowest mortality rates. And the other cause, again, we get the now traditional figure. So Hull, Manchester, Middlesbrough, Blackpool, Stoke-on-Trent are always in the top 5 or 10 highest mortality rates pre-pandemic. And again, this is coming out with what we've seen now, with the areas that typically have the lowest mortality rates and the highest life expectancy. So Kensington, Chelsea and Westminster, again, have really low and much below average mortality rates. That was just a very simple weighted average. So now if we try and drill down on this, and are these differences statistically significant? If they are, can they be explained by factors that we know are associated with higher mortality rates. So, for example, we know older people were unfortunately more likely to die from COVID. It affected ethnicities in different ways. People in more deprived areas were more likely to be affected because of the types of jobs they had. And they're also more likely to be concentrated in the north of England. And the underlying health structure. So we're going to measure that by the rate of people who are asked to shield. We can measure health in any way, but we get the same results. I'll show you here what happens if we proxy the underlying health of the population by the amount of people shielding. So for the economists in the room, I'm not claiming any causal associations. These are just associations. But obviously, the more covariates you include, the things that are linked to COVID-19 mortality, if the relationship remains, if the beta term on the north stays statistically significant, even after you control for deprivation, ethnicity, age, and underlying health, then that does start to reinforce this idea that there might actually be a true north-south effect, and it's not just because the north typically has more unhealthy people living in more deprivation. So if we look at the all-cause mortality rate, these are the coefficients. So the bar is the size of the coefficient, and the line is the 95% confidence interval. The model is as we were on the last slide, but we also separate the rest of the country out by with and without London, just because we know London behaved so differently to normal. And essentially the effects get smaller the more we control for. So these bottom 4 bars here, when we've got deprivation, then we've also got the underlying health of the populations. These 95% confidence intervals still don't cross zero. So the north still has a higher mortality rate. So 30 or 31 more people per 100,000 died in the north than in the rest of England, conditional on deprivation, health, age, ethnicity. So these things don't explain the full picture. There are unobserved differences between the north and the south, which is very likely linked to what Sophie was mentioning about austerity disproportionately hitting there. The health of the north is being affected worse by underfunding. So there's loads of historical unobservable reasons why these effects might still be there. We also get the same for COVID-19 mortality. And even when the rest of England includes London, given how badly London does, there still is a higher on average effect in the north and the rest of the country. And it gets very close to being statistically insignificant here, but the effect does still remain. So there were mortality rates. Some colleagues here in Manchester looked at excess mortality. So if we model what happened in the 5 years prior to the pandemic and then look at a predicted value for 2020, how much worse was mortality in the various regions of England compared to what we'd expect given historical averages, so the excess mortality. So this here is from that paper, and it essentially again shows the northwest and the northeast have the highest rates of respiratory related excess mortality, but also any cause mortality as well. So again, we get this very similar picture where the northern regions and the Midlands have the highest excess mortality, and the southern and eastern regions have the lowest excess mortality. So if we look at absolute numbers of deaths or excess mortality, we get very similar pictures. The IFS published a really good report the other month looking at hospital activity, because we know hospitals were very overrun with COVID patients. They opened the Nightingale hospitals, and the knock-on effect of that is, and routine care might be delayed, but we don't know if this was uniform across the country. And it wasn't. Again, we see that the Midlands and the north of England, and particularly Yorkshire and the Humber, had the biggest reductions in elective admissions, emergency admissions, and elective outpatient appointments, comparing March to December 2019 with March to December 2020. We also know from some of the work that we're doing on this follow-up report that I haven't shown here, is that the hospitals in the north of England, particularly in the northwest, had many more COVID patients, and many more beds were occupied by COVID patients. So we know that these people, these admissions that have been delayed, this fall in admissions between 2019 and 2020 will obviously require some treatment in the future. So the health of the North has got worse directly because of the pandemic, but these indirect effects are also likely to mean the legacy of the pandemic could live on longer in the North East, the North West, Yorkshire and Humber and the West Midlands as well. So that was all about mortality and hospital activity. If we look at mental health, because we know lockdowns increase mortality, there's lots of things that could and has affected people's mental health. So this slide here just looks at the general health questionnaire. So it's a self-reported questionnaire relating to self-perceived mental health and well-being in the last 4 weeks from the Understanding Society, or UK Household Longitudinal study data set. And what we've done here, we looked at changes in GHQ, conditional on age, gender, ethnicity, employment status, and other covariates, in the year 2019 to the year 2020. So all regions of the country experienced significant reductions in their mental health. But again, Yorkshire and Humber, North East and the North West were among the highest hit regions in terms of mental health. And London had the biggest fall in mental health, and again, given how much of the epicentre that was and how many jobs were lost there as well, that isn't too unsurprising. This is just mental health GHQ, average GHQ scores over time. So 36 is the highest possible level, and we know pre-pandemic the average was around about sort of 24.5, 25. And the lines show that each of the regions had a hit. But in the North, particularly at the beginning of the pandemic, the hit was much bigger. But then this sort of fell away a little bit. But when the regional lockdowns were introduced, we see this gap begin to re-emerge again. So that's self-reported measures of mental health. If we look at more different measures of mental health, so this is the number of antidepressants prescribed per person, from 2018 to 2021, and the North again is the North East, North West, Yorkshire and Humber. The rest of England is everywhere else. So the people in the North were more likely to be prescribed antidepressants, and also more per person. And again, this trend doesn't narrow. If anything, in the pandemic, it might slightly widen, but not noticeably so. But this gap is still there. And these reductions in mental health and health in general are important, because obviously health is so important to people's lives. We need health to be able to work, to enjoy ourselves, to have fulfilled lives. But we also argued in our first report that health was an important predictor of productivity. And if we break that down into mental health, there is a strong relationship between mental health and productivity. So people with low levels of mental health are more likely to leave the labour market, and if they stay in the labour market, they're more likely to have days, sickness days. So this isn't the way we want to frame this problem, but the government and policymakers seem to take more notice if you can frame the health effects in terms of a monetary return. And when we've done this in the past, there has seemed to be a little bit of interest around this. As Sophie showed, the train maps, here's one for the changes in unemployment. So this was between the first 2 months of the pandemic. And again, the North, particularly the North East and the North West, were really badly hit in terms of unemployment as well. And in the whole period that we've got data for, the average unemployment rate across the 14 months was the highest in the North East. The North West was third, and then Yorkshire and Humber were fifth. And again, London, particularly around Christmas, was badly hit, and that's what drives up that average. And again, these are just the trends over time in the unemployment. There was very little difference regionally when we looked at the uptake of furlough at a regional level. So when you go down to local authority and ward level, there are some big differences between areas, but at a regional level. And actually the North East had the lowest uptake of the furlough scheme, which sort of makes sense with the unemployment story. If more people become unemployed, there are few people left to be put onto the furlough scheme. So people in the North East were more likely to lose their job and hence lose their income and be put onto universal credit than they were to keep 80% of their salary through the furlough scheme. And finally, if we just look at median gross pay from the annual study of hours and earnings, so in the north, it's gone down very slightly by about £2. But in the rest of the country, it's sort of maintained, it's gone up slightly. But the striking thing about this, even in 2019 and into 2020, is how much less, on average, people in the north are paid than people in the south. These are just raw numbers. It doesn't account for the types of jobs people have. And when you do look at the standard occupational classifications for jobs, it explains a lot of this difference. But there are still some differences that remain after this. So people in the north are paid less and are more likely to lose their job as well. And then finally, using the Understanding Society data, we looked at more self-reported measures, or loneliness, whether self-reported they were put onto the furlough scheme, and the number of hours people worked. If they kept their job, we know people's hours changed. And we also looked at new and recurring universal credit claims. And almost all of these, with the exception of furlough, were worst affected in the north. It's a really pretty bleak picture. Everything we've looked at has been worse hit in the north on average. And the first report had a number of short and medium-term recommendations. And the follow-up report we're hoping to publish sometime in July has got some more recommendations in coming out of the pandemic. But I think the key recommendation is to really invest in public health, try and reverse the austerity. But as Sophie said, child health is so important. So we need, if we get children's health right, we know the life course effects. In childhood, as Heckman and people have said, is the time to intervene. If we get early years right, the rest of the life, it's easier to intervene in childhood than it is later on. So I will stop there. Thank you.
Thank you very much, Luke. A series of powerful messages today. Thank you. That was really interesting. There's a couple of points in the chat, and please raise your hands if you've got any questions. Can you see the chat, Luke?
Yeah.
Yeah, so one from Caroline, one from Patricia.
Yeah, so sorry, Caroline, we reverse coded GHQ, so 36 became the best instead of the worst. So we made all of the, we reverse coded 0, 1, 2, and 3.
All right, okay. So, yeah. So they were higher.
Yeah, exactly. So we initially had it the original way around, but then when we presented it, people didn't think it was intuitive that lower scores were better mental health, so we've just reverse coded it so that higher scores relate to higher mental health. So we've essentially, just reverse coded all the 3s into 0s, the 2s into 1s, etc.
Fair enough.
Thank you. And well, a point from Patricia as well, I think, about employment contracts and furlough.
Yeah, and I think that doesn't just relate to the northeast as well. So it relates a lot to seaside towns, people on the type of contracts that are very heavily reliant on the hospitality in industries, again, which tend to be more prominent in the northeast, part of the northwest coast, some in the cities. So the people who probably most needed the furlough scheme were probably least likely to actually be given it, because their employers thought it would be easier to let them go because of the nature of the contracts that they were on.
Okay, thank you. Stick your hand up if you've got a question. I've got one about, so you know, I know you've been looking at a lot of stuff, and this is just a snapshot of it, Luke, but I was wondering, you know, more on the input side, so the staffing, NHS staffing and medical staffing. Have you been able, or is anyone given any thought to, you know, the health of staff? Because this is going to impact on things as well. You know, not only are maybe hospitals in the north packed out, they're in a different way, but maybe the health of staff is different, availability of staff, you know, changes in staffing as well due to COVID and, you know, staff moving around. And it's always hard. Some parts of the country find it very hard to get staff at the best of times. So is there any work underway on that aspect of it as well?
There is, yeah. So it's not work that we are doing, but some colleagues in occupational health in Manchester have been commissioned by the Department of Health and I think the police as well. So it's the hospital staff and the police looking at how their health was affected, and what that's meant for staffing within the NHS, but also within the police and fire brigade as well, possibly, because of these people having to be in work and interacting with patients more often. And yeah, we don't know how that then had effects on rotas and what have you.
Brendan, did you want to say your question? I know I've just noticed you've typed something as well.
Yeah, that was something else, but
okay.
But yeah, thanks, Luke. That was really interesting. One thing I was thinking, and I'm sure the north-south effect is a real effect, but I think that also, say, there's a kind of London effect, isn't there? Definitely with education, but also if you're using IMD, the actual data behind the IMD is probably five years old. So there's a bit of a time lag issue where parts of London are becoming kind of, you might say, gentrified. They're becoming more affluent over time. So the IMD lags behind the actual level of deprivation more for London than other areas, and whether there's kind of ecological fallacy type issues as well, where the average IMD for an area doesn't represent concentration of problems in that area.
No, I think ecological fallacy is a real worry here, because yeah, within local authority. So Manchester, the local authority has got some really actually affluent bits and some really deprived bits. And on average, the deprived bits would dominate that ranking, but actually that's masking a lot of variation. That's also true the other way around, where some very affluent local authorities have some really deprived parts of their local authorities as well. But the trade-off always is the level of data and granularity, and then having statistics that the ONS will release and will be meaningful enough to get some inference from.
Thanks.
Okay, any final points for Luke?
So just following up on that, so by saying there is the north effect, so what is the point you're trying to make? So like, should we move all these people to the south, or should we bring more sun? Because like the thing, like for example, I saw on your list the 2-child limit, like the 2-child policy that was introduced 3 years or so ago, that affects the whole of the country. Do people have more children in the north?
I don't know off the top of my head. So that the whole policy recommendations is just giving more control to people in the north to make decisions about how they spend their public health budget. So devolution, Greater Manchester is having an experiment. There's some promising signs that it works, but we know that typically centralised, what usually are London-centric policies, don't work particularly well in the north. So it's just, we're not suggesting everyone moves to the south, but it's just that there's more autonomy given to the north, more localised devolution, decentralisation, and that people's health in the north is prioritised, because the graphics Sophie showed about the reductions in core spending power of the local authorities disproportionately hit the north, and there the health was the worst. So things were bad and they're getting worse. So we just need to think of something to reverse these trends. That doesn't involve everyone moving to London.
It's just because when you say it's the north effect, then you think, yeah, what's the answer then? Yeah.
Well, that's true. But then Katerina did move from the south to the north. But we have to move on to another. We have to move on to another question. A quick one from Mandy, and then we'll have Brendan.
So
thank you, Mandy.
It was just a quick one, really. There are other things that we do more in the north as well. So Blackpool is one of our hotspots for smoking and smoking in pregnancy. And I'm wondering whether, and you know, we obviously have high rates of CVD and high rates of respiratory illness, not just because of smoking, but also because of our industrial legacy. So I just wondered whether you'd managed to counteract that, or whether that might explain some of the north effect when you've taken some of the other things out of it. That was all.
That is a really good point, and we in the past used smoking prevalence and binge drinking as outcomes rather than mediators or moderators. So it would be interesting to see what happens if you look at them on a sort of causal pathway,
because they're not necessarily outcomes. I mean, they are connected to mental health and worklessness and that sort of thing, but actually they are causes of ill health. So from an NHS perspective, and it's something we've been working on quite a long time, on smoking in pregnancy. So I just wondered really if we could, because there might be interventions that we could take that would affect, you know, especially in pregnancy, you know, that whole cultural fallacy about having a small baby being a good thing that is absolutely clear in white lower economic groups, that is not the same in other groups with the same kind of economic status, and we see a massive difference in the outcomes for those pregnancies and those women. It's just a question, really.
No, that's something we can definitely look into. Thank you.
Thanks, Mandy. That's great. Thank you very much, Luke. For a big thank you coming at the end, but we'll move on now to Brendan's talk. So Brendan Collins is a tenure track fellow at the University of Liverpool, but also is head of health economics in the Welsh Government. So very timely that you've come along to give us a talk today. You're noticing a theme with the titles, obviously. We did think about this. So this is improving health and reducing inequalities, which programs are a win-win. So over to Brendan for 20 minutes and then some questions at the end. So thank you very much, Brendan. I can see your slides, but I can't hear you. You must be on mute.
There we go, unmuted. There we go. Okay, so as Bruce says, I'm a tenure track fellow. I'm a researcher in University of Liverpool. I've been on secondment to the Welsh Government since end of January last year. So my plan was to kind of go to Welsh Government and do some health economics, and I've just been mainly doing COVID stuff since then. These are my own opinions and not the opinions of Liverpool or Welsh Government, and anything here is in the public domain. So I think the objective of a public health system in a country like the UK should be to improve health and reduce health inequalities. We've still got very wide health inequalities that we've seen in previous presentations. And there's books like The Spirit Level and The Inner Level that show that health and social outcomes are generally worse in more unequal countries and states like countries like the UK, the US, South Africa. I would argue that a lot of planning in the English NHS is based on inequalities in demand rather than needs. And it's also based on people who are alive, so it doesn't always account for differences in survival. The budgets are based on, kind of per capita, but they don't account for investing in future generations or previous generations. I think this is still right in terms of the share of inequality, share of resources for inequalities in the NHS. So I think if you line up looking at inequalities in needs, demand and supply, you see different effects. So this is actually emergency hospital admissions rather than A&E, but you do see a similar pattern in terms of A&E, that you see more demand in deprived areas. But one thing is that the gradient in demand is a lot wider for something like A&E that's not constrained by supply than it is for something like GP practice appointments, where it's constrained a lot more by supply. So if you're happy to kind of go and wait in A&E for 4 hours or 8 hours or 12 hours, I mean, they do turn people away sometimes, but if you're happy to go and wait, then you'll be seen, whereas trying to get a GP appointment can be more tricky. As we've said this morning, COVID has exacerbated existing health inequalities, and I think it's illuminated them as well. So I think for people working in the world of health inequalities, it probably isn't kind of an opportunity to say, well, you think these things are unfair when we're in a pandemic. These things happen all the time. And so I think coming out of COVID, there's an opportunity to try and do more to reduce health inequalities as well as other inequalities. So we've got different kind of intersecting risk factors for COVID outcomes. So this is just an example of some of them. There are a lot more. So you might have someone who lives in overcrowded housing. They might have pre-existing health conditions. They might work in a risky job. So they might be a hospital cleaner or something like that, where they didn't get the same kind of PPE as people working in ICU. There might be a kind of age risk factor if they're over 60 but they're still working. You've got all of these things that kind of combine to create these kind of axes of inequalities during the pandemic and the rest of the time as well. So health inequalities accumulate across the life course. People aren't born necessarily with more health problems than others, but they accumulate as time goes on, and we need to decide what's the best time to intervene as well. I mean, I would agree with other people that I think early years is a time to intervene. The first 5 years of life is a really crucial time. Health inequalities accumulate across the treatment pathway as well. So there's this paper by Peter Tugwell and colleagues where you've got this idea of the Tugwell staircase, which is kind of looking across a treatment pathway, and it could be anything, where you've got maybe prevention, and then you've got sort of diagnosis, you've got treatments, you've got all these different parts of the pathway where the relative inequalities will accumulate across the pathway. And so if we're trying to design policy formulations to reduce health inequalities, we need to think across the whole pathway. So coming out of the pandemic, I think it is a time to prioritise. We know we've got a huge backlog in terms of NHS waiting lists for routine appointments and routine, procedures and things like that. We've also had a lot of natural experiments. So being brutal, there's a lot of people who've waited a lot longer for things that they would have normally had. So you can, if you're tracking their quality of life or you're tracking their health status, then it might be that you can see over time which patients have got worse, which patients have kind of maintained their quality of life. Obviously, there's other things to consider in there because different procedures and different types of treatments are either treating the problem right now or they might be preventing problems in future. And do we focus then on allocative efficiency? So how much we allocate to treatment pathways, or technical efficiency? So it might be investing more in certain elements of the pathway like diagnostics. There's this kind of Tony Collier bookshelf model of cost effectiveness thresholds where you've got a series of programs or interventions, and then you've got a cut off in terms of your budget limit. So if you see different programs as books, you've got different width books depending on what is the eligible population for those interventions. You keep adding books to your bookshelf until you've hit your budget limit, and then that's your sort of prioritization. But within this as well, you could also add in equity as an additional sort of criteria that you would weight these cost effectiveness elements to. So this is the traditional cost effectiveness plane, which hopefully you've seen, where in the northeast quadrant you've got treatments that are more effective but more costly. In the northwest, the old treatment is dominant, so you wouldn't invest in things that were in the northwest quadrant. And the southeast quadrant is where your new treatment is dominant, or your new intervention. It might be a public health intervention. So in that case, that would be a good case to invest. There's also the equity impact plane. So it's similar to the health equity plane, but it shows equity trade-offs on the two-dimensional plane, and it uses a summary measure of cost effectiveness. So because it hasn't got these two axes for your cost effectiveness, you'd use a summary measure like net health benefit, where you convert your costs into qualities, or net monetary benefit, where you convert your qualities into money. So you might have an intervention where you gain one quality, you value those qualities at £30,000, plus you have cost savings of £10,000, and the net monetary benefit would be £40,000 for that intervention, and that would sit at that point on the equity impact plane. And then on the other horizontal axis, you'd have a measure of equity benefit or reduction in health inequalities. So it might be changes in slope index of inequality or relative index inequality. There are a lot of debates about, how this should be done, and different people have done it differently. So it's still not kind of standardized. But this is the way it's kind of shown at the moment. So in the northeast quadrant, you've got interventions that are win-win, they're cost effective, and they improve equity. You might have interventions that are lose-win, so they're cost ineffective, but they improve equity. So they wouldn't be deemed to be cost effective using normal kind of standards, but you might still say, well, because they improve health inequalities, that might still be worth investing in. And you've got win-lose, so you might have something that's cost effective, but it harms equity, and you've got lose-lose, where it's not cost effective and it harms equity. So these are the examples of the type of measures that you might use on the line. So this is the slope index of inequality. So this is looking at life expectancy at birth for Hammersmith and Fulham. And you draw a line to show the gradients through the slope in life expectancy at birth by IMD. And that slope is the slope index of inequality. And this is the relative index of inequality. So this is where this is looking at age standardised rates of CHD mortality in Scotland by income decile. And with this, you would look at the gradients divided by the population mean. So this would give you a relative index of inequality of 1.5. And you would use these kind of measures. So you're basically looking at the gradients of outcomes by another sort of measure of interest. So it might be IMD, or it might be income decile, or it might be something else. So thinking about my intervention, if I'm looking at a program and I want to know, is it win-win? some examples that might be a win-win might be smoking cessation services. So if you've got smoking cessation services that are targeted particularly to deprived areas. So when I've looked at smoking cessation services in the past, I've evaluated them. They've usually been a win-win. So they've been reducing health inequalities as well as being cost effective. So producing a net health benefits. Something that might be a win-lose. When I've looked in the past, like breastfeed and peer support might be a win-lose because it's generating a net health benefit. It's improving health, but it's increasing inequality. So when I've looked at breastfeed and peer support, they've been mainly kind of taken up by more affluent mothers in certain areas. But with all of these things, it depends, I guess, how much they're targeted as well. So if you really target intervention and get uptake in deprived areas, then you can change your win-lose into being a win-win. And it might be the other way around as well. If interventions aren't well targeted, then it might move from being a win-win to being a win-lose. Something that might be a lose-win might be something that's not considered cost-effective by your kind of typical benchmarks, but reduces inequalities. So an example of this might be, and this is going back some years, is when Pemetrexed was approved by NICE for treating mesothelioma. So this was something that wouldn't be considered cost-effective by the traditional thresholds that they used at the time, which I think was £30,000 for QALY, but it was treating a condition that was associated with inequality. So mesothelioma is usually related to exposure to asbestos, which is more in kind of deprived communities. So it would be people who are working in industries like shipbuilding or house building and things like that. And it's also something where there weren't very many good treatments, and there still aren't very many good treatments. So this was an example where NICE kind of made a special case that they approved an intervention that cost more money, but it was reducing health inequalities. And lose-lose is something that's not cost effective and doesn't reduce inequality. So I'm sure you can think of lots of examples for that. But yeah, how interventions are targeted really matters. So, you know, you can change, something can change from being a win-win to being a win-lose. And I think it's being realistic about the population as well that you're targeting to, and, you know, who has certain diseases, because you've got competing causes of illness and death. So people in deprived areas are exposed to different risks over time. So it might be that some interventions, it's very tricky for them to be a win-win, but we still need to, you know, have a portfolio of interventions across the whole population. I think one area that I thought is quite interesting, where it kind of crosses this divide a little bit, is I think I might be getting this wrong, but I think that in the past, breast cancer incidence has been higher in more affluent groups, but breast cancer mortality has been higher in more deprived groups. So you can see that that's something where it looks like the treatment pathway might be one thing that makes a big difference. There might be other differences as well, but it's one of those things where it crosses that divide, where you've got higher incidence in affluent, but higher mortality in deprived groups. So if I want to know if my intervention is a win-win or not, I think we need outcomes data by IMD or by small area, or even individual data on socioeconomic position like income, education, if we want to make these kind of comparisons. Or it might be use kind of household level deprivation scores, things like the Townsend score, although these are not used so much anymore. And then this can be used to compare outcomes to the population at risk an intervention is targeted to, or to the population as a whole. So ideally, if you want to look at smoking cessation, you might compare it to the prevalence of smoking across IMD quintiles, let's say. But you might also look at comparing it to the population as a whole and seeing whether you've got, you know, uptake and outcomes in your most deprived areas. And so, I mean, in the past, I guess I've looked at quite a few different public health interventions. So look at things like weight management. And also, you know, I'm talking about generally sort of socioeconomic inequality, but you can look at things by all different groups. So it might be by ethnicity, or by age, or by gender, or any other type of group, really. So one thing that you might use is a social welfare function, where you transform health outcomes based on population preferences of the value of health benefits. So there have been studies that have been done to look at people's preferences for health benefits in more deprived versus less deprived populations. There's a paper which I think estimates a kind of 7-to-1 ratio in the general population, where they value health benefits to the most deprived 7 times those in the least deprived. So you might start where you've got kind of health gain measured in QALYs or something else by deprivation quintile. And then you'd apply a social welfare function, where it'd basically be like a multiplier for each of those, where you might weight benefits in the most deprived more, you might weight benefits in the least deprived less, because they've got better health status starting out. So it's I suppose it's trying to move people's health status closer to the population average. So overall, if we're thinking about the cost effectiveness equity plane, I think what we want to aim for is a win-win portfolio of interventions. So we need to accept that not all interventions will be a win-win. Not everything will reduce health inequalities. And there's also a timing issue, I think, for a lot of interventions. So if you've got kind of new technologies, it might be that they're taken up more by more affluent people at first, and then eventually it will kind of filter down to more deprived populations. But I mean, ideally, you do want to sort of aim for your portfolio of interventions to be reducing health inequalities. And so I think it's kind of looking at trying to find ways to measure that. And I don't know if anyone's really kind of squared that up in terms of measuring it, but I think that's something we want to aim for. So, sorry, I'll just go back. So this kind of blob on the chart shows where your portfolio of interventions might sit. So you might have a few that kind of lose-win. You might hopefully have quite a lot that are a win-win, and then you might have a few where they're kind of win-lose. You might accept that you're not going to reduce inequalities with those interventions, but it might be very cost effective. And also, if you've got an intervention that's really cost effective and it saves money in the NHS or in social care or whatever in the future, then even if it reduces inequalities, sorry, even if it increases inequalities, it might be that it frees up more money to spend on other interventions down the line that will reduce inequalities. So it's thinking about that kind of health production cost as well that you've got in NHS or in public health or whatever you're looking at, where if you can generate cost savings, then those can be reinvested in something else. So there's some examples of where people have weighted these kind of things on health equity plane. So I'm flashing them up here, but I'm not the person to answer questions. So if you've got any really technical questions, then you're probably best going to the authors or reading the papers. But these are some examples. So there's the ScotFo III project, which looked at the impact on inequalities and overall health of different interventions. And this was a really interesting project because it looked not only at sort of classic healthcare interventions, so it looked at things like smoking cessation and counterweight, which is a weight loss type program, but it also looked at more social interventions, so things like creating jobs or things that kind of sit in the middle or having a living wage. And you can see that some of the things, the inequalities impact. So this shows the inequalities impact on the vertical axis, so it's slightly different to what I showed you before. The things with the biggest reduction in inequality was a 10% rise in job seekers allowance or income support. So basically, giving people more money, which is maybe not a big surprise, had the biggest impact on health inequalities. And then you've got life years gains as well on the horizontal axis. So you can see that a living wage had the biggest impact in terms of life years gains on this. And I think it's really interesting because it was comparing the same amount of investment. So it's comparing spending £5 million on any of these things. What do you get for your money in terms of health impact and reducing health inequalities or potentially increasing health inequalities? So you can see, for instance, active travel, it looks like it probably increases health inequalities a little bit, and that might be because active travel is maybe taken up slightly more by people in more affluent areas. So that's one example, and then and so it's just circling some of the ones I've shown there. And then another example is some work that was carried out by Susan Griffin, Leslie Owen and others, which looked at NICE public health interventions that have been modelled for NICE since they started looking at public health interventions in, I think it was 2006. And it looked at them on the equity plane. So it's got the reduction in the slope index of inequalities and population health benefits. And you can see that a lot of them fall into the win-win quadrant. So a lot of them are reducing health inequalities and producing a net health benefit, but some of them fall into the other quadrants. So yeah, this is an example. And I think, the methods that they used were really clever methods where they sort of took the inequalities in hospital admissions for different causes, so different disease groups, and then applied those different disease groups to the NICE public health modelling that had been done in the past. I think this is useful, if you wanted to look for some interventions that are win-win, then you could look at this paper and say, what should my local authority be doing, or what should my NHS CCG be doing? So to summarise, should we even talk about equity trade-offs? I mean, if one of the core ambitions of public health is to reduce inequalities, then how can we have these trade-offs? You might say that equity is like human rights. It's one of these things that we should just happen, and we shouldn't look at it. But I think the reality is these trade-offs do already happen, and talking about them illuminates them. And I think making the case for a health system with a good mixture of programs, a portfolio of interventions that reduces health inequalities on average, but recognizing that not every individual intervention might reduce health inequalities. And it is possible for health systems to reduce inequalities. So the English Health Inequality Strategy from 1997 is an example of this. And German reunification is another example of policy efforts reducing health inequalities. So after German reunification, there was a lot of money put into East Germany to try to kind of level it up, and life expectancy gaps between the East and the West narrows very quickly after German reunification. So I've nearly landed bang on 20 minutes, so I'll stop there, and thank you, and I'll stop for any questions.
Thanks, Brendan. Perfect timing. And again, a third powerful talk from a different perspective, really, I think, in terms of what can be done in policy terms, well, how we could potentially get policymakers interested. Mandy, your hand's up. Is that a legacy hand from the last round of questions? Yep, looks like it. Okay, has anyone else got any questions? I've got one about policy. I'll kick off quickly. I mean, given where you're working at present, Brendan, in the government, I'm not asking you to give anything away here, but using your experience day to day, and maybe things have been, different in COVID times, is this something that policymakers would be willing to take into account? Because I think they're kind of used to the nice cost effectiveness thing and what that means, and it's you can get that idea over pretty quickly. Is this extra, putting equity in there as well? And I think it's great putting it into something they can recognize. Have you tried this out? Is it something that's, easy for people to get their heads into?
Yeah, it is something that I've been pushing. It might not surprise you that it's something that I've been pushing quite a lot. I think it is. I think probably I think showing things on the equity plane is really powerful, and I think it's a good way of thinking about things. There's issues around obviously trying to collect good quality data about interventions and the equity impact, or because I mean, otherwise if you're using nice guidance and things like that and HTAs and trials and things like that, they don't usually include those equity impacts and trials. The way they're designed won't really include it very well anyway. But so there's data issues around it. I think there's probably issues around the kind of technical side, especially of how you show the impact on inequalities. So do you use SII, do you use RII, do you use something else? And do you compare the impact on inequalities of the intervention on its own to the people having the intervention, or do you try to compare it to quality adjusted life expectancy across the whole population? Because ideally you would do the latter, but it's quite complex to try and do that. But yeah, I think overall policymakers are receptive to it, and I'm hoping that we will try and use it in Wales. So there's a programme in Wales called the WESRI, the Welsh Health Equity Status Report Initiative, which is a collaboration with the World Health Organization that Public Health Wales are leading on, and I'm hoping that some of it will be used as part of that programme. They're trying to create a kind of online tool which shows equity impacts of different policies in Wales, and also shows the position around equity in Wales. So I do hope that I can kind of get people to use it, but it's thinking about good examples and trying to get the data to be able to do it, I think is a tricky part.
Absolutely. Any questions for Brendan? Okay. Thank you, Brendan. So a big thank you from me, from all three speakers, and from everyone, I'm sure, in the audience. We're not quite finished yet, so don't disappear, audience. Thank you to Sophie for kicking things off and setting things up with pre-COVID, and thanks to Luke for the over to Luke bit of the talk with COVID. So all very powerful. We are recording this now, and I'll ask the speakers, but I think they'll probably let you have their slides as well. So they might not, but they might. So I'm hoping they will. And thanks to Brendan for finishing off really by looking at the policy slant and how we can get people to take notice of inequalities and what we might actually be able to do about it. So really, really powerful talks and lots for us to reflect on and think about in the way we do things. Thanks everyone again for coming along. When you fill the survey in, which I'm sure you all will, because you're all really good at this sort of thing, and we'll be very grateful. We'll reflect on the results. As I say, we've got an idea for the next meeting to do with discrete choice experiments and how they can help, because we've had quite a few inquiries already about them. So that's will feature in the next meeting, but we might do some other things as well, depending upon what happens. We'll send the date round for the next meeting. We'll send it round before the end of July, so you can get it in your diaries in good time. We'll base a date of that meeting on what you just told us and what you tell us in the survey about how often you'd like the meetings. Finally, just really thank the speakers again. Thank you all for coming. If you've got any ideas in this group, put them in the survey or get in touch with us by email. So Valerio, Angela, or myself, whoever you're more comfortable sending the messages to, that would be fantastic. So we're looking forward to having a group which isn't just academic seminars. It's really driven by what people in the Northwest Coast want to know about in health economics and want to feel supported by health economists, if that's possible. So we're really looking forward to interacting with you over the next few years. And thanks very much for coming along today. And I hope you all enjoy your summer and the afternoon ahead, even though it's just started pouring with rain here. So thank you all very much. Have a great afternoon, and we'll see you soon. Bye for now.